includes what happens before delivery. The basics need to be covered, and the maternal and fetal risk factors need to be assessed to anticipate those who might need resuscitation. Part 2 consists of the first 30 seconds of life. Once the baby is delivered, the time of birth is noted. Next, the baby is dried, kept warm, and its airway is cleared if necessary. If breathing doesn't begin spontaneously, further stimulation might be needed by briefly slapping or flicking the soles of the feet and rubbing the infant's back. Next, Part 3 takes place within 1 minute after birth and includes a quick delivery room assessment consisting of 3 questions. If the answer is no to any of those questions, further evaluation is needed. If the infant is apneic or gasping and has a heart rate under 100 beats per minute, positive pressure ventilation by mask and pulse oximetry monitoring are started. If, after 15 seconds, the heart rate is not increasing and stays below 100, ventilation needs to be corrected. Alternatively, if the heart rate is increasing after 15 seconds, positive pressure ventilation is continued and the heart rate is reassessed after 15 seconds. If after 15 seconds it's increased to 100 beats per minute or more, and spontaneous effective respiration has begun, positive pressure ventilation is discontinued. If the heart rate remains under 100 beats per minute, take ventilation corrective steps. And if the heart rate is under 60 beats per minute after taking ventilation corrective steps, intubate the infant, initiate chest compression, and reassess ventilation. If the heart rate remains under 60 beats per minute, administer intravenous epinephrine. If the heart rate is persistently under 60 beats per minute, epinephrine may be repeated every 3 to 5 minutes. If there's no heartbeat or respiratory effort for more than 10 minutes, resuscitation efforts may be discontinued. Alternatively, if upon further assessment, individuals present labored breathing or persistent cyanosis and a heart rate above 100 beats per minute, check the airway position, monitor oxygen saturation by pulse oximetry, and provide supplemental oxygen. The most common cause of respiratory distress in newborns is transient tachypnea of the newborn. The diagnosis is clinical. The onset is at birth or within the first 2 hours of life, and it lasts for 12 to 24 hours. Chest radiography can support the diagnosis. Management is supportive, consisting mostly of supplemental oxygen administration. Second, respiratory distress syndrome is diagnosed based on the clinical picture of a preterm infant with the onset of progressive respiratory failure shortly after birth, in conjunction with a characteristic chest radiograph. Regarding treatment, nasal continuous positive airway pressure is the preferred initial intervention. If this fails and apnea develops, the infant requires endotracheal intubation and intratracheal surfactant therapy. Part 4 starts 1 minute after birth and after resuscitation has ended. It's when the APGAR score is calculated at 1 and 5 minutes after birth. And finally, Part 5 is when a brief physical examination is performed to check for any signs of disease. It should start with observing the infant's general appearance and body measurements, followed by auscultation of the lungs and heart while the infant is lying quietly, and by a head-to-toe examination. Additionally, the infant also might need prophylactic eye care with erythromycin, vitamin K1 to prevent vitamin K deficiency-related bleeding, and vaccination for hepatitis B virus.